Good evening. I'm very excited to welcome you to the first ever Global Surgery APSASode. I'm Tamara Fitzgerald from Duke University, and I'm the chair of the APSA Global Surgery Committee.
And I'm Jay Krishnaswamy from Dornbecker Children's Hospital and Oregon Health and Science University, and I'm the co-chair of the APSA Global Surgery Committee. We're excited to present this session focused on pediatric surgery for children all around the world. During this session, we'll be presenting the APSA Humanitarian Awards, and we will hear 5 abstract presentations focused on the surgical care of children in low and middle income countries. The theme for this conference this year is workforce issues in pediatric surgery. And so we will end this session with a special presentation about workforce issues in low and middle income countries.
This year, we have 2 APSA members who will be the recipients of the Humanitarian Award. I'm honored to announce our first award recipient, Dr. Michael Kirchi. We will now watch a tribute to Dr. Kirchi prepared by Edmund Taganda in Rwanda.
Hello, greetings from the heart of Africa. I am Dr. Ntaganda Edmond. I am a pediatric surgeon from the Centre Hospitalier Université de Kigali. On behalf of the APSA Global Pediatric Surgery Committee and the APSA Board of Governors, I have the privilege to present to you the laureate of the Surgical Humanitarian Award of 2021, Dr. Michael Kirchi.
As a medical student at Columbia University, Dr. Kirchi spent 2 months in Liberia, which initiated his interest in surgical care for patients in low-income countries. He sought out further opportunity during his 3rd year of surgical residence at Yale New Haven Hospital by completing a 3-month rotation in Haiti at the Albert Schweitzer Hospital and then returning during his chief year for an additional 6 weeks. This association began in 1969 and continued for 50 years. Dr. Kirchi practiced as a pediatric surgeon in Portland, Maine from 1976 to 2008 and was the General Surgery Program Director from 2000 to 2008. During his career, he was able to return countless times to continue his global surgery effort in Haiti, involving his family members, residents, fellow faculty, and nursing staff from Maine Medical Center. Dr. Kirchi retired from his USA practice in 2009, which enabled him to focus his global surgery effort in East Africa. He initially worked in Tanzania for 3 years, 8 months per year, training non-physician clinicians, and briefly in Malawi.
So Dr. Michael Kirchi is a renowned pediatric surgeon, and I have the honor to call him a friend. So I met Dr. Kirchi in 2013 when he was part of a joint venture between the government of Rwanda and the consortium of American universities that was put in place to develop the human resource for health in Rwanda. And he has been among the very first to come to join this program. Since that year until last year, 2020, he has been coming for 3 months at a time, and he has not missed a single one. And his experience as a program director for general surgery has been instrumental, and the role of Dr. Michael Kirchi in developing a pediatric surgery service has been key by inspiring young consultants and residents that were trained by him to join the pediatric surgery career, myself and my younger colleagues. So Dr. Kirchi's unrivaled teaching abilities, his dedication to work, and his incredible human qualities have enabled him to have such a wonderful and long career, and we have been lucky and privileged to be part of this journey.
I am both pleased and honored to be one of the recipients of the Humanitarian Award for APSA this year. My professional career has been defined by education and service, but what has been most fulfilling recently has been the development of a pediatric surgery service in Rwanda where none previously existed. When I arrived in 2013, there was no pediatric surgery services for a population of 12 million people. By 2020, we had 2 dedicated, board-certified pediatric surgeons to provide excellent care for the pediatric population in Rwanda. This was Dr. Edmund and Dr. Elan Jules in What Could Be Better. Dr. O'Neill, in a presentation at the 2017 APSA meeting, expressed 2 thoughts which continue to resonate with me, and I would like to quote this evening. He said, "There are certain values that can be neither taught nor tested for surgical learning that only a humanitarian experience and role modeling can provide. For me, this is the heart of the global experience." In addition, he quoted the words of the Kijabe chaplain Mercy, who said, "If you come to Africa, take 2 hearts because you will leave one there." This has certainly been true for my wife and myself. Thank you again for providing this honor.
I have the privilege of announcing our second Humanitarian Award recipient, Dr. James O'Neill. Dr. Ken Mumma, a longtime collaborator of Dr. O'Neill's from Kijabe Hospital in Kenya, has prepared this tribute.
Hello, everyone. My name is Ken Mumma, a practicing pediatric surgeon and the program director at Bethany Kids Pediatric Surgical Training Program at Kijabe Hospital, Kenya. I would like to start by stating that this man I'm about to speak about is not short of people who can speak highly about him, including in this APSA audience. Therefore, I consider this an honor. This man, who I consider to be my father and my lifelong coach, is a legacy statement that I cannot exhaustively speak about in 3 minutes. And so, I do not want to pretend to do so. Before coming to Kenya, Jim and his wife Susan had done some international humanitarian work in Guatemala and in Shanghai, where they helped in building of our children's hospital through the Project Hope. Jim and his wife Susan began coming to Kenya in 2007. Initially, they both worked in the local public hospital in a small town around 80 kilometers outside of Nairobi City. Jim trained the local general surgeons in some basic pediatric surgical skills, as his wife Susan assisted the nursery nurses and the new mothers by birthing the babies. Jim then got introduced to Bethany Kids at AIC Kijabe Hospital by Dr. Mark Newton, a pediatric anesthesiologist working at the same hospital. As they say, the rest is history. Therefore, through their involvement, we have achieved the following together. We have a flourishing pediatric surgical training program that has trained pediatric surgeons for 9 countries. He has personally been involved in training of 4 pediatric surgical fellows in the same program. Together with Mark Newton, they have been involved in mobilization of a training grant that has gone to assist in training numerous pediatric surgeons and the pediatric anesthesiologist. He is a catalyst in institutional collaboration between Vanderbilt and AIC Kijabe Hospital. The collaboration has resulted in an external rotation for Vandi general surgery residents at AIC Kijabe, which continues to be viable and flourishing. He has participated in research collaboration, especially in the Wilms tumor study with Professor Kiambi of University of Nairobi and Vanderbilt. When in Kenya, Susan takes time to play with the children and read for them storybooks after or before they have had their operations, therefore providing complementary holistic care. He supported Eric Hansen, the former program director for the Bethany Kids training program, and he has also supported me, and he continues to support other faculty in the same program. I asked Susan to help me get into Jim's mind and explain to me what motivates him so that I could understand his life philosophy. She says it is Jim's love for people that keeps drawing him to where there is need. They therefore consider it a privilege. My personal story, well, I have benefited immensely from Jim's and Susan's friendship. I am one of the former fellows, now a pediatric surgeon, who was taught by him both in the wards and in the operating room. I have learned many things from him, but above all is his humility and love for people. They therefore form lifelong friends, and in the most genuine way. Their passion for my people, for the Kenyan child, for me and for my family is intrinsic and immense. They have taught me that you can change the world with little actions, even from 13,000 kilometers away. I am proud that he has mentored me and many in Africa. Thank you very much.
I was moved by Dr. Mumma's generous introduction in his remarks. I truly appreciate his kind words. It is much more than I deserved, as many more people have been involved in this work. I also am grateful to Dr. Mumma and his family for their friendship and for the work that they do at Kajabi for the children of East Africa. Sarah Mumma is a pediatric oncologist who has worked tirelessly, almost all by herself, on behalf of children with malignancies. And I am particularly grateful to my partner in life, Susan, for her unwavering support of our overseas work, especially for her efforts in child life and maternal support. I don't think there is a lady in East Africa who doesn't know how to knit because of Susan's daily work. I'm grateful to Eric and Amanda Hansen and many others at Kajabi for welcoming us over the years and for the way that Eric Hansen has demonstrated how much good a superbly talented surgeon can do for children. I'm grateful to Mark Newton, the pediatric anesthesiologist at Kajabi, who is my academic and clinical partner, who has transformed that aspect of care in East Africa through training. And of course, I want to thank APSA for this award. Of course, it is something I am accepting, not for myself, but for all of those wonderful people at Kajabi who have devoted their lives to God's service to others. I accept this gift from APSA, but I am mindful of my father's words to me on one occasion: don't expect rewards for something you should be doing anyhow. I encourage all of you to consider working in this field, not just for personal gratification, but for the good you can do for children who have no access to care otherwise. Many, many thanks to all of you.
Congratulations to Dr. O'Neill and Dr. Kirchie. Thank you for your dedication to global surgery over the years. You have inspired so many pediatric surgeons, both at home and abroad. Also, a special thanks to Dr. Edmund Taganda and Dr. Ken Mumma for their tributes. Now, I would like to introduce the first abstract, which will be presented by Thomas Diehl, a retrospective review of gastroschisis in low resource settings. Can antibiotic stewardship reduce late inpatient deaths?
Thank you to the APSA Global Pediatric Surgery Committee for this opportunity to share our work. We do not have any disclosures. Mortality due to gastroschisis ranges between 75 and 100% in low and middle income countries, but is less than 4% in high income countries. Early deaths, those that occur less than 48 hours after presentation, are often due to system issues such as delayed transfer and inadequate resuscitation. Late deaths, those that occur greater than 48 hours after presentation, are often due to a mix of system issues and patient factors such as sepsis, slow gastrointestinal recovery, and malnutrition. While antimicrobial resistance is a widely acknowledged problem in low and middle income countries, The exact patterns of antibiotic use and resistance in Rwanda are unknown. In our study, we aim to understand antibiotic use for gastroschisis at a referral hospital in Rwanda and identify modifiable factors for increased survival. We conducted a single-center retrospective review of 3 years of data for all patients presenting with gastroschisis to the University Teaching Hospital of Kigali, which is the only hospital receiving gastroschisis patients in the country. Our primary outcome was survival to hospital discharge, and secondary outcomes included antimicrobial usage, time to abdominal closure, and time to enteral nutrition. 92 patients presented with gastroschisis during our study period. Approximately 50% were male and 50% female. The average gestational age was 36 weeks, and most patients arrived on the day of birth, with an average age at arrival of 0.6 days, which is about 14 hours. Overall mortality was 79%. In the early death category, 8 patients died within 24 hours, and 21 patients died within 48 hours. In the late death category, 42 patients died before hospital discharge. Looking at antibiotics, 96% of patients were treated with antibiotics on arrival, and 21% of patients received extended spectrum antibiotics such as carbapenem and vancomycin during their stay. About 86% of inpatient hospital days were spent on antibiotics, and on univariate analysis, antibiotic selection and timing of delivery did not predict survival. Looking more closely at a subset of patients in the late death category who survived the first 48 hours in abdominal closure but died before hospital discharge, compared to patients who survived a hospital discharge, the days spent on antibiotics, time to abdominal closure, time to initiation of enteral feeds, and total length of stay were similar between the two groups and therefore did not predict survival. Mortality from gastroschisis remains high in Rwanda. Frequent late deaths seen in our study population highlight the need to prospectively evaluate nutritional support and antimicrobial stewardship. Our study is limited by lack of culture data and susceptibility data. Still, the high proportion of hospital days on antibiotics and frequent use of second-line agents such as vancomycin and carbapenems raise concern for resistance. These findings are being used to inform a prospective neonatal surgical registry, which is currently being developed at the University Teaching Hospital of Kigali. I'd like to take a moment to thank my co-authors and especially my mentors, Dr. Edmund Ntiganda and Dr. Robin Petrozzi. My contact information is listed here at the bottom of the screen. Please feel free to reach out, and I look forward to answering any questions and continuing this conversation. Thank you.
Thank you for that nice presentation and this important effort in Rwanda. I just have a few questions for you. The first is, who pays for antibiotics in Rwanda? Are they provided by the government hospital or do patients pay out of pocket? And how does this influence the antibiotic selection?
Yeah, thank you so much for that question, and thanks for inviting me to be part of this discussion. I'm really honored to be here. Regarding the financial impact on antibiotic selection, the majority of patients are insured through community-based health insurance called Mutuelle de Santé. So patients do pay a portion out of pocket through co-payments that are based on income level, ranging from 10 to 15% generally. There is a smaller subset of patients who also have private insurance. So antibiotics, whether purchased at a government hospital or a private hospital, are mostly covered by insurance with somewhere between a 0 and 15% copay. There are also several mechanisms in place and social workers available to assist families who are unable to afford the copay. So affordability is very rarely a consideration for antibiotic selection. One caveat is that rarely there are families who are unable to afford the antibiotics in time. So antibiotics are purchased at the time when they are needed, and any other medications are also purchased in that fashion, meaning that the medications are paid for in advance while the rest of the patient's hospital care is paid for at the end of their hospital stay. And so there have been rare instances of missed doses or delayed doses of antibiotics when families are unable to afford the copay in time. But this is a rare event, and in general, affordability does not affect antibiotic management.
Well, that's great. Okay, my second question was, you did not find a difference in mortality with different antibiotics. Statistically, this may be because the mortality rate in the study was so high. What antibiotic regimen will you be recommending going forward? And do you have a plan to standardize antibiotic coverage?
Thank you for that question. That's a good point that high mortality rates make it difficult to detect a statistically significant mortality effect size with our data set. Our early retrospective data presented here highlights the importance of culture-driven antibiotic selection. So one of our main goals of ongoing work at the University Teaching Hospital of Kigali is to institute a clinical protocol that takes into account antibiotic sensitivities and includes infectious cohorting for resistant bugs. So since this data was collected in 2019, the surgical neonates have been cohorted in a specialized unit, and blood cultures are now routinely collected at admission and with any clinical change. So we hope to create a more sophisticated antibiogram to understand antibiotic resistance patterns, which will likely influence our first-line antibiotic empiric treatment when patients first arrive with gastroschisis, and also help us to develop a more culture-driven antibiotic selection from there.
That's great. Well, we'll be looking forward to a future abstract about that. My third question is whether you're currently following any particular clinical protocol for babies with gastroschisis.
Yeah, great question. There is no Rwandan gastroschisis protocol per se. The hospital follows international guidelines for gastroschisis management, but of course these have to be adapted some to the local limitations. Some of these limitations include rare availability and use of TPN, and relatively rare prenatal diagnosis, which then requires postnatal transfer to a tertiary care center, just to name a couple of the issues. However, the neonates are increasingly coming from centers where the local providers are aware of the key tenets of gastroschisis management, so sterile bowel covering and IV fluid resuscitation. And so in many cases, proper treatment is initiated prior to arrival at the tertiary care center. And then once they arrive at the University Teaching Hospital of Kigali, there are protocols in place for the pediatricians who receive these patients initially in terms of IV fluid management, temperature control, sending off cultures when they arrive, and surgery is called to place the preformed silo and bedside reduction where appropriate. So developing this team approach has been really key, and cohorting the neonates in a specialized unit has been important and made it possible to train personnel and standardize care.
Our next abstract will be presented by Dr. Megan Burkhold, and her abstract is entitled Childhood Morbidity and Mortality in Francophone Africa Due to Typhoid Intestinal Perforation.
Hello, my name is Megan Burkhold. Thank you to the organizers of this conference for the opportunity to participate and present this research. Today, I will be presenting on childhood morbidity and mortality in Francophone Africa due to typhoid intestinal perforation. We have no disclosures. As a brief background, there are about 10.9 million cases and 116,000 deaths annually attributed to typhoid fever. The most feared and life-threatening severe complications include gastrointestinal hemorrhage and typhoid intestinal perforation. Mortality rates in resource-limited areas are disproportionately high. Pediatric populations are greatly affected, with a peak incidence seen in children ages 5 to 9. Recently, the WHO recommended the use of a new typhoid conjugate vaccine pre-approved for ages 6 months and over in endemic areas. The aim of this review was to update the literature on typhoid intestinal perforation in children living in Francophone Africa. We conducted a literature review for studies reporting mortality rates due to TIP in children under 21 years old living in this area that were published since January 1995. In addition, we included unpublished prospective data collected by one of our authors from a rural tertiary hospital in Niger. There were 1,225 articles identified through our search. After duplicates were removed, abstracts screened, and full text review, 7 studies met the inclusion criteria. 4 studies had information on length of stay shown in the table. The average length of stay was 11 days to 30 days, with the longest reported at 67 days. This table shows 7 studies included in our review. As you can see, 3 studies are from the Ivory Coast, 2 from Niger, and 1 each from the Central African Republic and Mali. Study years spanned from 1990 to 2015, and the number of patients in each study ranged from 31 to 153. 4 studies reported a postoperative morbidity rate, which ranged from 16% to 52.8%. Mortality from TIP was reported from a low of 6% to a high of 29%. And this is considerably higher than the mortality rates seen in high-income countries, which is usually less than 1%. The next table shows some commonly reported postoperative complications from the 5 studies that had information available. Surgical site infection percentages ranged from 14.3% to 64.6%, and enterocutaneous fistulas ranged from 1.1 to 12.5%. Other common post-op complications included wound dehiscence, evisceration, and incisional hernias. And again, many of these percentages are considerably higher than what we see in high-income countries. Limitations of this review include the quantity of studies available. There are likely other studies published in local and regional journals that are difficult to find through general search methods. Second, generalizability is difficult since data was limited to only 4 of the over 20 Francophone African countries. And third, all of the study hospitals were teaching hospitals, so data could be different in non-teaching hospitals and those in more remote and rural areas. So in conclusion, mortality rates due to TIP remain high, unacceptably high in these areas. SSIs account for most of the postoperative complications and contribute significantly to morbidity rates. Improvements in access to care, including surgical services and antibiotics, and in water and sanitation infrastructure and hygiene programs, are needed to help reduce these high morbidity and mortality rates. However, these are expensive and often difficult to implement. So prevention of typhoid fever is therefore key and would be improved with the introduction of typhoid conjugate vaccines into routine immunization programs. These are my references. And I would like to thank my co-authors, mentors, and the TIVAC team at University of Maryland for their support, and the APSA and everyone involved in this conference. Thank you.
Thank you for this interesting study. I have several questions. You mentioned that one of the limitations of your study was that the number of studies was small. Why was the study limited to only the Francophone countries and not the Anglophone countries in the region? And then as a corollary to that, for those who aren't familiar with this distinction in these areas, is there a fundamental systems, demographic, or treatment difference between these groups of countries?
Sure. So I had previously done a review on typhoid perforations in sub-Saharan Africa as a whole, and noticed that there was a lack of data and publications from the French-speaking countries. So I decided to focus on those countries to see if I could find more information on perforations in children. So I searched additional databases and also asked my co-authors to help find studies in regional journals that I didn't have access to. So for the second part, I think that's a very complicated question with a lot of contributing factors. I don't know if there's any differences between these groups, but I do think that in general, French-speaking countries do tend to be lower on the Human Development Index, unfortunately. And I think being landlocked with internal and border conflicts and multiple diseases to be concerned about all contribute to this.
Thank you. So in the opinion and observations of local providers and yourself, why is the mortality for this disease so high? And were there any risk factors noted in the published studies or the prospective data collection that you mentioned as to what the risk factors associated with mortality were?
Sure, that's a great question. In talking with surgeons on the ground in these countries, they said a lot of their patients do try traditional medicine first before coming to the hospital. So the progression of the infection is further along when they do end up receiving treatment, and this increases their risk for higher morbidity and mortality. Additionally, the longer they wait to receive care and the longer duration of their symptoms, the higher their mortality risk is. Many of these children are also malnourished, which puts them at a disadvantage from the start. And lastly, many of these areas are not able to do blood cultures. And with the spread of multi-drug resistant typhoid, this is increasingly becoming a problem, especially because physicians don't know if the antibiotics they're using effectively treat this disease. So that also increases mortality.
Thank you. So last question, is there any indication what the vaccination rates currently are and whether they are improving?
Yeah, so unfortunately, typhoid vaccines are not currently used in these countries or on the African continent in general. Zimbabwe did do a mass vaccine campaign due to an outbreak a couple years ago, and the rates of typhoid and perforations in children did decrease after this campaign. And then last month, Liberia was the first country in Africa to introduce typhoid conjugate vaccines, which have been pre-qualified by the WHO via a mass vaccine campaign. And they've also included this into their routine vaccination schedule for children, which is very exciting. So the Typhoid Vaccine Acceleration Consortium, or TIVAC, is working with Gavi, the Vaccine Alliance, to help get TCV introduction more widespread across the continent, which will hopefully help to decrease morbidity and mortality related to this disease.
Thank you, Dr. Burkhold. Our next presenter will be Paul Truchet, and his abstract is titled Defining the Global Surgical Workforce to Meet Under 5 Child Mortality Rate Targets in the Age of the Sustainable Development Goals.
My name is Paul Truchet, and on behalf of the Global Initiative for Children's Surgery, I am pleased to present our work defining the global surgical workforce to meet under 5 child mortality rate targets in the age of the Sustainable Development Goals. We have nothing to disclose. In 2015, the Lancet Commission on Global Surgery proposed a surgical workforce of 20 to 40 surgeons, anesthesiologists, and obstetricians per 100,000 population for all countries by 2030. The UN Sustainable Development Goals also set child and neonatal mortality targets for the year 2030. The target of 20 to 40 SAO is based on overall surgical system strength and may not reflect the unique needs of children. We wanted to examine a different, more holistic approach to workforce recommendations based on overall health system strength for children, which is commonly measured through childhood mortality rates. We aim to determine the association between the surgical workforce and childhood mortality across 192 countries and estimate the minimum surgical workforce density required to meet these targets. We obtained data for 192 countries, including SAO density and additional country-level covariates from the World Bank Open Database and WHO Global Health Repository. Our primary outcomes included under 5 and neonatal mortality rates developed by the UN Interagency Group for Child Mortality Estimation. Multiple imputation was used to handle missing data. We performed linear regression, adjusting for potential confounders of child mortality in order to evaluate if the size of a country's surgical workforce is independently associated with lower mortality rates when adjusting both for operative volume and non-surgical confounders of child mortality. We used unadjusted basis spline models to define minimum workforce targets and used adjusted basis spline models to define optimal ranges of surgical workforce scale-up where mortality benefit would still be observed. We chose to use B-splines because they represent a flexible approach that does not impose a strictly linear relationship between covariates and outcomes. We adjusted for a number of confounders related to child mortality, as well as surgical volume, defined as the number of operations per 100,000 population, which is a representation of the amount of surgical care delivered by each country given its existing workforce, and thus may capture how much surgical infrastructure is available to support the surgical workforce. In our model, we found statistical significance between SAO density and both under 5 mortality and neonatal mortality. We determined a minimum SAO density of 10 was associated with a child mortality rate of less than 25 per 1,000 live births. The graph above depicts the unadjusted relationship between child mortality and SAO density with a best fit line using a B-spline curve. The estimated marginal median plot of our adjusted model on the left suggests that for the average country, an even lower SAO density may be independently associated with meeting child mortality targets. On the right, you can see that reductions in child mortality are seen throughout the scale up to 18 SAO, suggesting that optimal SAO to support children's surgery may be well aligned with the Lancet Commission's minimum targets. We determined that a minimum SAO density of 12 was associated with a neonatal mortality rate of less than 12 deaths per 1,000 live births, which can be seen depicted on our unadjusted spline model above. Here, on our adjusted model, the marginal median plot on the right shows the rate of decrease in neonatal mortality is highest from 0 to 16 SAO, but continued benefit may be seen up to 70 SAO, suggesting that there are mortality benefits for neonates with scale-up to SAO densities typically observed in high-income countries and far beyond the Lancet minimum targets. In conclusion, increases in surgical workforce size is associated with reductions in both child and neonatal mortality, with a minimum scale-up of 10 to 12 SAO recommended to meet the SDG targets. Investment in surgical workforce scale-up, along with the infrastructure to support them, is a viable strategy for countries looking for additional ways to meet the SDG targets for child and neonatal mortality. Thank you. Please feel free to reach out to the authors via Twitter or email with any questions. To find out more about the Global Initiative for Children's Surgery, please visit our website at globalchildrensurgery.org.
Thank you for this very interesting and informative studies. I have a few questions. Whether data reflects correlation versus causation can often be a limitation of such big data as was collected in your study. How do you know the effect of SOA density is not just a reflection of the overall strength of the healthcare system beyond just workforce, including enhanced access to care and service delivery, better health information systems, leadership and governance at the systems level, or even just improved access to technologies like vaccines or imaging?
Thank you for this question. So this is definitely a critical issue for many broad epidemiological studies, and is certainly a limitation in our case when looking at national level data. In this study, we adjusted for a number of factors that try to capture the overall health system strength, including hospital infrastructure, urban population levels, and even competing causes of death in an effort to control for overall health system strength. But certainly it's not possible to completely control all of these factors, especially things like leadership and governance that can be difficult to capture from a data-driven approach. We do believe that regardless of whether this is a cause or an association, our results represent reasonable benchmarks that can be taken in context of other health development targets as ministries of health invest in health system infrastructure and workforce to support children's surgical care.
Great. Now, surgeons, anesthesiologists, and obstetricians also perform very different functions. Do you have information on which one of the three components of S, A, or O have the greatest impact in affecting the measured outcomes in any given country? I think that info might be helpful for countries that are trying to develop their workforce and need to decide which of the three aspects that they need to focus on the most.
This is a really excellent point and definitely an area for future research. Currently, very few countries report disaggregated numbers on the individual makeup of SAO. However, that is improving. The World Federation of Societies of Anesthesiologists is compiling national numbers of anesthesiologists. And there are some other groups looking to try and look at the specific breakup of S, A, and O. The Lancet Commission specifically did not break down provider types, but I do believe that understanding the makeup of SAO and how that workforce impacts outcomes at a population level, including where specific types of workforce gaps exist, is going to be critical to inform global surgery initiatives. This topic is kind of further complicated for children's surgery, as subspecialist surgeons are necessary to support complex congenital care, while general surgeons may provide the bulk of general pediatric care in a lot of LMIC settings. And we also do have data that obstetricians play an unappreciated role on neonatal mortality. So when you're looking at under 5 mortality, there's a huge benefit that having an adequate obstetric workforce brings to that. So I agree it's really critical, and that future research should look into what the different ratios of SAO are globally and how those may impact children's surgical outcomes.
Last question. Since so much of the peri-op care is really delivered by our nursing colleagues, it's interesting that you found that it's surprising that the nurse and midwife density did not correlate with mortality. Can you explain why that might be the case?
Yeah, that's another excellent point. So in our study, one problem was we couldn't capture specifically OR nursing. So nursing care, as it's reported by the World Bank, includes both the nursing and overall midwife community, but does not break down specialist nurses. And in fact, that's further complicated by the fact that many countries don't actually have subspecialist nursing training or certification. So it can even be difficult to really quantify how many nurses are actually working in operating rooms. I believe that the inability to tease out nurses who specifically support perioperative care is probably the reason that we did not find that the nursing density impacted child under 5 surgical outcomes. But I do think that the role that nursing care plays in the overall healthcare workforce to support children's surgical care is critical, and that working to better define the population of nurses who are supporting perioperative care will allow us to answer questions about what optimal OR nursing levels may be.
Great, thank you very much.
Our next abstract will be presented by Alicia Sykes. Estimated number of preventable deaths in the first 8,000 days of life by scaling up surgical care at first level hospitals worldwide.
Good afternoon, and thank you for the opportunity to present our research. Over the past 20 years, significant progress has been made toward improving child health worldwide, with most of these efforts focusing on reducing the mortality of children under the age of 5. There has been a growing recognition that the healthcare needs of older children must be addressed, as recent evidence suggests that the mortality of these children is much higher than previously thought. An evolving theme involves a focus on the first 8,000 days of life, which represents a critical period of growth and development for children. Surgical care is a critical yet often overlooked component of universal child health care and can play an important role in reducing child and adolescent morbidity and mortality worldwide. And surgical care is often delivered at first-level hospitals in low and middle-income countries due to their close proximity to rural and underserved populations. Therefore, we sought to estimate the number of deaths that could be prevented in the first 8,000 days of life if basic surgical care were universally accessible at first-level hospitals in low and middle-income countries. For our original abstract, we performed this study using data from the Global Burden of Disease 2017 study. However, in order to provide a more updated analysis, we repeated our analysis utilizing the Global Burden of Disease 2019 study data, which was released immediately following submission of our abstract. Population data were obtained from the World Bank database, and countries were grouped by World Bank income group rather than World Bank superregion, as the latter combines countries of various income levels. We performed our analysis utilizing a counterfactual methodology previously developed for Disease Control Priorities 3rd edition, and included in our model 3 digestive diseases, 4 maternal conditions, and 8 common traumatic injuries. We found that over 600,000 deaths per year could be prevented in the under 20-year age group if surgical care would be scaled up at first-level hospitals in low and middle-income countries. The vast majority of deaths occur in lower middle-income countries and low-income countries, with approximately 92% of preventable deaths occurring in these 2 income groups. And the majority of preventable deaths were due to maternal causes and injuries, followed by digestive diseases. Within the maternal conditions category, the vast majority of preventable deaths were due to neonatal encephalopathy due to birth asphyxia and trauma. The most common causes of preventable deaths due to injuries were due to road injuries and falls. And within the digestive diseases category, the most common causes of preventable deaths were paralytic ileus and intestinal obstruction, followed by appendicitis. Maternal conditions represent the greatest burden of preventable deaths in low-income and lower middle-income countries, followed by injuries and gastrointestinal conditions amenable to surgery. Causes of preventable deaths vary by age group. Within the under 5 age group, the largest number of preventable deaths are from maternal conditions, and preventable deaths from maternal conditions increase again in the 15 to 19 age group. Injuries and gastrointestinal causes are represented across the span of childhood, with injuries being the most common cause of preventable deaths in the 5 to 19 age group. In conclusion, approximately 600,000 deaths of children and adolescents under age 20 could be prevented each year by scaling up surgical care at first-level hospitals in low and middle-income countries. The majority of preventable deaths are in lower middle and low-income countries, with the largest burden of preventable deaths being attributable to maternal conditions. Injuries account for the greatest percentage of preventable deaths for children and adolescents aged 5 to 19 years. And improving surgical care to treat maternal conditions could have a profound effect on the under 5 mortality rate. Thank you.
Thank you. That was a very nice analysis. Your model is based on data from the Global Burden of Disease database. Can you comment on how accurate this database is for pediatric surgical conditions? For example, many data collection methods rely on hospital records, and many babies with congenital anomalies may die at home and never produce a hospital record.
Yes, thank you for your question. The Global Burden of Disease study is the gold standard for global health analysis and is used by both the World Health Organization and the World Bank. It includes data on mortality and morbidity for 204 countries and territories, 369 diseases and injuries, and 87 risk factors. The data collection is considered very accurate because it is cross-validated in a variety of ways and includes data from vital and sample registration systems, disease surveillance point systems, demographic surveillance systems, household surveys, and censuses. And even in countries with little to no data from a working vital registration system, they derive mortality rates from sibling survival modules. The Global Burden of Disease study does not include comprehensive data on specific pediatric surgical conditions, and updates to the database are unlikely to include this comprehensive data. Therefore, rather than trying to estimate the global burden of all pediatric surgical diseases or conditions using this database, we used it to model what would happen to the under 20 mortality rate by scaling up basic surgical care at first level hospitals.
Great, that was a great solution. My second question is based upon your study, what are your recommendations for scaling up pediatric surgical care, and how should APSA members be involved in this?
Sure, so based upon our study, we would recommend the building up of entire health systems in low and middle income countries with an emphasis on improving the obstetric and trauma care. So our study found that directing efforts at improving maternal care has the potential to prevent a large number of pediatric deaths due to complications from preterm birth and birth asphyxia and trauma. And we would recommend APSA members becoming involved in the Global Initiative for Children's Surgery, which has brought together medical and surgical providers, nurses, and other healthcare providers from all over the world who are passionate about providing surgical care to children. This group is working alongside global partners to promote and provide surgical care for children worldwide. And you can find them online at globalchildrensurgery.org or on Facebook by searching GIC Surgery. Thank you.
Thank you so much. Our final abstract will be presented by Marko Mezic and is titled Global Collaboration in Croatia.
Dear colleagues, ladies and gentlemen, greetings. I'm Marko Mezic, pediatric surgeon from Children's Hospital Zagreb, Croatia. Croatia is a small Mediterranean country. The capital is Zagreb and has a population of 4.2 million people. It has a beautiful nature, 1,000 islands, long and rich antique and medieval history with a landscape diversity. Children's Hospital Zagreb is a central institution for health care for children and adolescents in Croatia. And what we are very proud of that the first World Congress of Pediatric Surgery was held in Zagreb in 2004. The collaboration continued in the years that followed, especially with Cincinnati Children's Hospital Medical Center, due to friendship between our director Bakhtiarovich and Professor Aziz Khan. In 2016, colorectal team overseas, led by Mark Levitt, visited Croatia and performed difficult colorectal operations. The collaboration continued in the following years. I would like to especially emphasize our collaboration with Professor Velchik. Her husband was a Croat and she was visiting Croatia very often, but we didn't know her until the day when her friend's son, the little boy from the city of Sadar, where Professor Velchik has her apartments, was diagnosed with Hirschsprung disease. Parents decided to continue treatment in our institution, and Professor asked if she can join us in the OR, and here we are. Every time Professor visited Croatia due to family obligations, she joined our team and helped us with difficult cases. I will mention some of the most complex of them. The child, which seemed to be a cloaca patient, eventually happened to be a urogenital sinus with colonic atresia at the level of ascending colon and ileal duplication. The child had 3 ureters, solitary pelvic kidney, uterovaginal duplication. Another patient, which seemed to be a cloaca patient, happened to be colonic atresia with no vagina and ectopic attachment of left ureter. In this case of urogenital sinus, we applied a different approach from a standard PSAR procedure, doing anterior approach with sphincter preserving technique developed by Professor Gottmeyer. With her help, these kids were able to be treated in Croatia instead of going abroad for further treatment. Professor also joined us when we were doing Hirschsprung cases and helped us with the rare congenital anomalies of the hepatobiliary tract. The biggest turning point happened in 2019. Department of Pediatric Surgery is a regional center for short bowel syndrome and motility disorders led by Professor Kolachev and Professor Hojsak. Before 2019, the most challenging patients have been sent to Brescia, Italy, for bowel elongation. Since we had a lot of patients with difficult post-operative problems coming from all around the region, Professor suggested that she could train us and help to develop a national program in our institution, especially because many patients returning from abroad had complications we had to deal later in our institution, and we were ready. In January 2019, we did the first step procedure in Croatia. By the end of the year, we did 7 of them. Now we are doing them routinely. No matter how small are you, no matter how difficult it seems to probably be, with the help of true friends, you can do everything. So with collaboration with Professor Welchik, the practice of pediatric surgery in Croatia has been changed forever. Nice regards from Croatia. Thank you very much.
Congratulations on a successful long-term collaboration. It's clear that this partnership is making an impact. Can you say a bit more about what impact this partnership has had on the surgical trainees at your hospital?
Well, well, the answer on this question is very simple, it's priceless. Every man is a little wheel inside the system, and he's working, and in every generation has some kind of mission to maintain this machine, to keep working on. So we are all invited to leave some trail in the time in this hospital we are living in. So to improve ourselves is not only an individual mission, this is some kind of mutual development. And they say that when the student is really ready, the teacher will appear. So my generation was very happy and lucky in the same time, because we have a teacher, and whatever we learned really enriched us with new techniques and knowledge, and of course, it changed perspective of our work. So people are usually often ready to take some things for granted and to forget how difficult it was to learn and to implement them. So I'm sure that my trainees were very aware of the knowledge they got in, and this is not something very short. This is something what is in continuing. It is happening for all of these years. So the one word is priceless.
Great. My second question is, a lot of APSA members are interested in getting involved in global partnerships, and a lot of them don't really know where to start. What would be your advice to members of APSA who are thinking about getting involved in partnerships?
Well, maybe I will be philosophical again, but surgeons are a very interesting population, especially surgeons in the small countries. So as soon as they realize that they don't know nothing, or that they are making mistakes, and that their knowledge is very limited, or there is some kind of problem they can't solve, you may consider yourself as a good material for learning. So not every surgical community, especially in small countries, is a good soil for partnership. For example, Professor Welchik, in the beginning, she spent several months trying to establish good professional relation with two other departments of pediatric surgery in Croatia, but unsuccessfully. They were not enough humble and mature to accept that they are doing some things wrong. So I may say that we were lucky, but that's not something strange, because almost every surgeon, pediatric surgeon and pediatrician in Children's Hospital Zagreb was educated in USA. And we have a very long relation with Professor Aziz Khan, with and our former directors. They were friends. So you have the first Congress of Pediatric Surgery held in Zagreb. So we have a tradition, and we were all the time, we were very close to USA, more than any other community of pediatric surgeons in the world. So after 2 or 3 months in America, it definitely changed. And what I remember was a motto in Cincinnati Children's Hospital: change the outcome. So the best way probably to establish the partnership is to enable different types of observerships and present them on national regional conferences. Also, great help is to have a surgical net where you can get the expert opinion, what can be also individual and also hospital level access. But probably the best partnerships are with young people who will approach individually, searching for answers. I think they are the best the best people where you can with whom in the future you can work. But that was all very philosophical. I may eventually say that my work, Professor Welch, is probably something I can't explain. You know, it's a God touch. So, so thank you.
All right. Well, thank you for that. Great
God
advice.
providence. God providence.
Thank you for that great advice.
Thank you.
Congratulations again to all of the abstract presenters. Now, the theme of this year's APSA is workforce. So we are particularly excited for our next segment, where members of the APSA Global Pediatric Surgery Committee interviewed pediatric colleagues from around the world to discuss the workforce challenges that they face and the solutions that they are pursuing.
We are pleased to learn from the following pediatric surgeons: Ahmad Shaltaf from the Palestine Medical Campus, Tamina Banu from Chittagong Research Institute for Children's Surgery in Bangladesh, Fernanda Dantas from Federal University of Accra in Rio Branco, Brazil, Dr. Bu from the University of Medicine and Pharmacy in Ho Chi Minh City, Vietnam, David Dalakian from the National Polytechnic University of Armenia, and Emmanuel Ame from the National Hospital in Abuja, Nigeria. We would like to thank these colleagues for their dedicated service to the children in their regions and for educating us on the status of the global pediatric surgery workforce. And now we will watch Expanding the Global Workforce for Children's Surgical Care, Challenges and Solutions.
What can you tell me about the numbers of pediatric surgeons in your area? What is needed? What do you have? What is the level of training? Tell me about all of that.
In West Bank, we must know that we have two parts of Palestine. It is the West Bank and Gaza Strip. In West Bank, I have exactly number. It is around 16 pediatric surgeons in West Bank.
And for how many people?
Population in West Bank, it is around 3.5 million.
Okay, so 16 pediatric surgeons for 3.5 million people.
Yeah.
Okay. And is that enough, do you think?
No, it is not enough for us.
In terms of the workforce itself, what about the other services that are very critical in what we do, like nursing, anesthesia, other pediatric specialists? Are those also significant deficits? And if so, which of those outside of the pediatric surgeons do you think is probably the most critical deficit?
Yeah, so across board, all our pediatric workforce have significant deficits, but I think the biggest of them is anesthesia, because in the entire country, we probably have less than maybe about 3 to 5 trained pediatric anesthetists. Every other person, they are general anesthetists. So that creates some problem for us. So I think that's the biggest workforce that has the biggest deficit. Nurses also, pediatric trained nurses are also quite few. In most of our hospitals are general nurses, not pediatric. So that creates some problems for us. I think we have a good number of pediatricians, but then the other pediatric, special pediatric oncology is a problem. We don't have any pediatric pathologists at all. So everything is done by general pathologists. pediatric radiologists are just a handful. And what that does to us as pediatric surgeons is that we practically have to interpret all our imagings ourselves, because the adult radiologists, they will interpret them the way they interpret for adults. So that creates some problems for us. But I think the biggest deficit is in pediatric anesthesia.
Tell me about the pediatric surgery workforce in your setting.
We have only in two centers, both are children's hospital, one in Dhaka Shishu Hospital, Shishu means children, and another in Chittagong, Chattogram, Mao Shishu, Mother and Child Hospital. They have dedicated nurses, anesthetists, and other supporting staff. But in other centers, they are, because the pediatric surgical facilities are part of the general hospital, so we share with the anesthetists, the nurses, and other supporting auxiliary staffs. And because Bangladesh has a predominantly young population, our patient overload is huge. We have to deal with, say, today I saw 14 major cases of pediatric surgery this evening only. And in the morning, I have to see around 50 patients. So the patient load is huge.
Are there deficits in the pediatric surgical workforce? And if so, where are these most pronounced? For example, nursing, anesthesia, surgeons, etc.
We do not have pediatric critical care specialists at the moment, only in 2 centers. And we do not have neonatal surgical intensive care unit, only 3 in Bangladesh at the moment. And in the peripheral regions, because the pediatric surgical facilities are mostly situated in the divisional city, urban areas, these are also not uniformly staffed.
Like, if I'm doing the math right, we have well over 24 surgeons for within a city of 1 million people. And even if we consider all of the 3 million population for the entire country getting their care in the capital, it certainly doesn't seem like there's a shortage. In fact, there may be somewhat of an overabundance of pediatric surgeons for the country. And so quantity-wise, it doesn't seem like there's a shortage problem. There may be the opposite problem, but how does that, in your mind, translate to quality?
In Armenia, the bachelor education program is like 5 years at the university, and then you go get your master's degree. It's called like that. You finish your basic education, and then you go to the residency program. So to become a pediatric surgeon, you need to finish your university, and then you need 3 more years to become a pediatric surgeon. Basically, in a country with a population of 3 million people, I think you cannot get enough experience to operate yourself and be a pediatric surgeon that can operate all by himself, for example, in some of the regions, and don't need any help from a senior colleague after graduating this program. So the second issue is our professional associations that don't have any legal status. They are considered as NGOs. So there is nothing like a board certification for a specialist. You get your license when you finish your residency program and you are considered a pediatric surgeon, for example. And there is no particular document that certifies that you can do these or other procedure and you are qualified to do that procedure. Or hospitals apply for a license to have, for example, a pediatric surgical department in their clinic. And that clinic is not a multidisciplinary clinic. It's just an adult clinic that has different adult services, but only one pediatric department where they operate maxillofacial, ENT, general surgery, and everything. If they have all the necessary equipment listed on the paper, they have the wards, they have the, I don't know, electrosurgical unit, anesthesia machine, and different kind of equipment, they get the license. Then they start hiring people. They find a couple of newly graduated guys and they say, hello, we have a new team with young specialists and they can do everything. Okay, you are welcome. So, but who's gonna deal with the complications? If they get any complications, they transfer these patients to a highly professional institution like our hospital or two other hospitals that are already present in the city. So, I mean, there's a liability issue either.
I know that you have been through Global Initiative for Children's Surgery, and you personally in Nigeria have been very involved in the development of national surgical health plans. Can you tell me a little bit about, from a workforce standpoint, obviously surgical health plans are influenced by those who can deliver the care. Has there been any, what are the aspects of the National Surgical Health Plan, if any, that maybe address the workforce issue? And have you seen any traction because of the development of a National Surgical Health Plan?
Children's surgery as a specific component of the ENSO, and that included scaling up workforce, research, training, and infrastructure. Since the ENSO document for Nigeria was launched, this was 2019, implementation, by the way, started sometime last year. And for children's surgery, I think we are making some progress, because one of the things we've been able to do in terms of the implementation is we've now created a national registry that will help us to collect data in a very reliable manner, collect data on surgical procedures, starting with birth defects. So that went live, and it's an electronic registry. It went live early this month. So we are starting as a pilot, and we are hoping that in the next few years, we'll be able to expand it across the country and then collect data, because without data, really, there's not, it's difficult, even the advocacy we talk about. So that's one aspect that is happening for children's surgery.
If we come and have a visit to your hospital and help provide some training or education and so forth, does that help you or does that not help you? In other words, does that take away the time that you need to be doing your work to try to get your job done and to try to pay the bills?
Yes, of course, you help us a lot. Before to answer this question, so I would like to explain more about the our pediatric surgery workforce in my country. So even the distribution between the geographic region and different level in level of health facility, and another part is we have a large gap between the general surgeon, and most of our physician and nurse are very young, over 35 years old. And now in our department, They there are just four over 20 surgeon is over 35 years old, and more than a half is surgeon just graduate from medical school from 1 to 2 to 3 years. So we have a large gap in the the large gap of knowledge and skill. So to fill the gap. Yeah,
I see. That's surprising to hear you say about the youth. I mean, how young the doctors are. Is that because the more experienced doctors have retired or left medicine altogether for other more lucrative fields, or where they can earn more money?
Yes, some of them are retired. Some of them left. They quit the job. Right. Yes, yeah, or maybe some of them left to the private hospital.
I see. Okay, so then money is one of the factors that is resulting. The fact that a pediatric surgeon in your hospital can only make a certain amount of salary means that some of the experienced pediatric surgeons are leaving that hospital and going to other places where they can make more money in the private hospitals or the private clinics.
Yes, that's the big reason, but not explained for the whole the situation here. Yeah.
Yeah, interesting. So, because I've worked with several of at least more than one surgeon that I've worked with has left medicine altogether, into training someone who's very skilled at what they do, and then it's sad to see them leave. Anything that you see changing with that? Is the government aware of that problem? Are they trying to address it? Can they give more salaries? Are there bonuses? Are there any incentives that can get people to stay in pediatric surgery and medicine?
Yes, the RMOH and the director board of the Children's Hospital, they try to let our salary more higher, but it's the progress is slow. Yeah.
Is there something else we can provide other than coming and educating as often as we can, pandemics notwithstanding? I mean, is there other things we can do to help guide you or address any issues that you need? Do you find that, in other words, when we come, is it helpful if we bring anesthesiologists or nurses or others that you think that might help improve the standard of care in other areas of delivery of surgical care to children?
Well, I think as a perspective as a faculty member, so I think the most important is still training.
Problems have you experienced in the coordination of care for your patients? So, the process of a child being diagnosed with an issue that you can solve surgically through the entire process of actually getting them to the operating room and performing the operation, and then the post-operative care. I know you touched on some of the experiences during COVID-19, but kind of overall longitudinally, what is your experience with that sort of process of care coordination?
So I think that the care coordination is one of our biggest problems. In fact, that's one of our biggest problems. We don't have this a good regulation. So I have to work on it personally, to make calls, to call the patient, and we don't have intelligent coordination, especially here at Amazonia. We don't have prepared managers, and we don't have just like arrows, or it doesn't work. So me, the only pediatric surgeons, I have to make it almost by myself, each of these steps, to be able to put the patient inside the OR. It's really, really hard. It's just like an obstacle running. So I have to pass over all the obstacles, and I have to fight against the anesthesiologists that doesn't want to make this anesthesia to my patient. I have to fight against the nurse, the chief of the OR. So I feel that children are always a problem. The system is not made for children. The system is made for adults. So we are disturbing the just like the NP at United States. I could give attention. I could attend much more patients, but I have to do every single step by myself and fighting against the system. So I think that this question, it was great. It was one of the biggest problem, and maybe one of the biggest solutions also.
What do you think you need most to improve surgical care for children in Amazonas? What do you think would be the most important things to improve care?
People here, they are committed to the patient, especially in the children's hospital. They are committed to the patient. They want to do what is best, but they don't know how to do it. So I think that we should have someone to help in these organizations. And I think that we have poor resources, but we don't use it in a good form too. So we lost a lot of poor resources that we have, and it could be much more useful than it is. I would love to train the team. When I have arrived here 16 years ago, I was just like the new thing. And I have trained all the nurses that were working here. I have trained the pediatricians. I have trained the neonatologists to identify that kind of diseases that we treat. I try to teach the general doctors how to identify our kind of diseases, how to take care of the patients and send the patient to me without causing hazard to the patients. So I take care of them, and then I have trained them how to take care of the postoperative period too. So how you change a wound, how you take care of a drain, a central line, or a thoracic drain, something like that. But we have lost this during the years. So old people have retired. We have new people here, but I am not the new element anymore. So it's not easy for me to make that kind of when I have arrived here, I just like shake the structures. Oh, something new, and everyone was dead and now they are surviving. But I think that we must train again our team, and they are committed to that, but we must train that. And I think that one of the biggest problem is that we don't have an excellence environment here. Do you understand? So I will not do my best because I don't have the resources. I will not make this effort because I know that's not going to happen. But with the low resources that we have here, we are able to do better for sure.
What can an HIC partner help you specifically do to help address the workforce deficits, in its many facets that we've spoken of today?
So I think one of the most beneficial partnerships, maybe of recent, is when we approach the kids operating room to help us create a children's operating room, and they asked us, "What do you want?" And we told them what we wanted, and we worked together to create and come up with what exists today. So I think that was quite successful. They didn't just come and tell us, "Look, we think you need a children's operating room. We are going to create one for you, and this is what it will have." They didn't do that. We told them what it wanted. What we wanted. So I think that's the kind of partnerships that we want. Research within Nigeria, in my hospital and in my particular practice, I've worked with several HIC colleagues on research projects, and some of them have been very successful because we did it in a mutually beneficial way. But I think when it comes to research, the crucial aspect that is missing at the moment is that of funding, because obviously most of the funding comes from HICs, and at the moment, I think the distribution and utilization of those kind of funds is very asymmetrical to the advantage of our HIC colleagues.
On behalf of the APSA Global Surgery Committee, we would like to thank all of our interviewees who took the time to share their experiences with us, and all our interviewers who helped to make this possible. Thank you.